you about epidemiology. Then you had to tell the etiology. For example, you can remember in your occlusive arterial disease, the etiology means generally atherosclerosis, then the risk factors. Okay, that kind of thing. Then pathophysiology. Okay, so pathology, before that pathophysiology. So, for example, take diabetes and hypertension, then the pathology is atherosclerosis, and you tell something about how it develops. Okay, the development of atheroma. Then you come up with signs and symptoms. Okay, then you go on to the differential diagnosis and investigations. Then you treatment prognosis, like that. Okay, so the wound lecture also, you can take individual things and describe. Anyway, you start with the definition. So wounds come for your short cases as well as for your long answers. Okay, so what is the definition of a wound or an ulcer as opposed to an abrasion? Okay, so wound is a full thickness breach in the continuity of the skin. So full thickness as opposed to partial thickness, which you will come to know as an abrasion. And full thickness is a wound, whereas a partial thickness is called abrasion. The difference is wound heals in a different way compared to partial thickness abrasion. Okay, so let's have a look at it again. And when you talk about wound and the wound healing, you have to know the anatomy of a normal skin. Okay, so abrasion will not involve all the layers of the skin. Okay, so what are the layers? Epidermis and dermis. Okay, so if only the epidermis is damaged, you don't call it an wound. Okay, you call it an abrasion. So what's the difference? Epidermis will heal by regeneration of the underlying germinal epithelium. Okay, so you don't see a scar. Okay, is that clear? When there's an abrasion, you won't see a scar. Okay, but when there's a whole thickness, so full thickness loss, you will see a scar. Okay, so everybody will show you a scar. That means a full thickness was damaged sometime. Okay, so full thickness heal in a different way. So we had to know the stages of healing for you to understand abnormal healing. So normal healing, if you read an article or go through books, you will get various wordings at various times and you get confused. Okay, but I would suggest you give only these 4 stages and try to figure out under which stage you are reading it in the book. Okay, book may use a different word. Anyway, go through the description and see which stage they are talking about. Is that correct? So go under these 4 categories when you describe or when you understand, and when you read books or articles, try to figure out which stage they are actually talking about. Okay. So soon after wounding, imagine there's a traumatic laceration of the skin. Okay. So soon after wounding, any wound, whether you like it or not, it's going to bleed and form a hematoma. Okay. When you leave a hematoma for a certain number of hours or days, then it becomes a dry scab. So that's the first step. Hematoma formation. Can you all hear me? Hematoma formation. Okay. Can you all hear me?
Yes, sir.
Yes. And for hematoma formation and proper hemostasis is essential for all the wound healing. Okay. If a hemophilia patient develops a wound and he keeps on bleeding, you don't expect the wound to go through the rest of the stages. Okay, so hematoma formation and hemostasis is essential. With this, what happens is there will be platelets and neutrophils within the wounds. Okay, and these platelets and the endothelial edges at the edge of the wound will release some factors which will induce the rest of the stages. Okay, so proper hematoma formation is essential. This is followed by an infiltration of inflammatory cells, acute inflammatory cells into the wound, which is called the inflammatory phase. Okay, so when you look at it from outside, what you see is surrounding skin is erythematous. Okay, if you see a surgical wound also, you may notice this. In 2-3 days, it would be erythematous. That doesn't mean it is infected. It is actually in an inflammatory stage. Why it is in the inflammatory stage? when the wound is lacerated, it's not going to be, it's going to have foreign bodies, it's going to have bacteria, and it is going to have dead cells as well. So when these things are present, the wound is not going to proceed to the next stage. Therefore, the inflammatory cells will remove these things. Okay, so when the inflammatory, following the inflammatory phase, there will be infiltration of cells producing various materials. For example, fibroblast, endothelial cells. So these cells will lay down the matrix. So there's a cavity as a result of laceration. So there will be many individuals who had a cavitating wound, but you don't see any people walking around with cavities. You see only people walking around with scars. So what has happened is cavity was filled with a granulation tissue. Okay, so that is a phase. So in the proliferation phase, the cells move into the wound and produce extracellular matrix and blood vessels. So that phase is, you can call it a proliferation phase or granulation tissue formation phase. Similarly, inflammatory phase, if you go through some books, some may call it the Debrimo phase. Both are same, okay? The purpose is same. So that's what I told. If you see a stage which you haven't heard of, just go through it and see whether what they are talking about, okay? And when the wound is filled with granulation, then it will be covered completely with epithelium, and then the wound closes. Okay, when the wound closes, now you have seen many scars and you have seen enough of granulation tissue also. Can you all name a difference between a scar and a granulation tissue? So the one difference is scar is not the granulation tissue is not yet covered with epithelium, but scar is covered with an epithelium. But other than that, can you spot a difference between scar and the granulation tissue? What's the difference? Any answers?
Sky is smaller, sir.
Okay, smaller. Okay, so there must be some contraction of the wound. Okay, that you had to, of course, ask the patient. Okay, what the size of the initial wound. Okay, anything else? So,
So the number of blood vessels.
yeah, how do you know that? What is your observation in that case? Yeah, number of blood vessels are less in which
Scar.
scar. Of course, correct. How do you say that?
So because the granulation tissue looks reddish and it shows a small in close observation, it shows some blood vessels also.
Yeah, if you take, for example, goes and rub on the granulation, it's going to bleed. Okay? It's going to bleed, isn't it?
Yes, sir.
Indicating it has lot of blood vessels. But if you take a stick and hit on the scar, is it going to form a hematoma? No, it's not going to form a hematoma. Okay, they are quite avascular. Okay. So what has happened from granulation to a scar is the number of blood vessels reduces and the fibers changes in type. For example, type 3 collagen becomes type 1, more strength. Okay, so that phase is called the maturation phase. Or some books may call it a remodeling phase. Some books may call it, like one of you said, contraction stage. Okay. So these are the 4 phases. You may have noticed I haven't written the epithelialization as a different phase. Okay, epithelialization will only complete the covering when the wound is filled. Okay, so that may take from 1 day to 2 days to a month also in our word. Okay, is that clear for you all, the wound healing phases and various words?
Yes.
Right, so various words, you just read through it and see what they are actually describing. Okay, right. Now, even though I have described in 4 distinct bullet points, these things won't, in nature, it won't happen in bullet format. Okay, so that means the hematoma finishes, then inflammation finishes, then the granulation finishes, not like that. There will be some overlap. So you may have seen granulation, little granulation tissue forming while the hematoma being evacuated, something like that. Or you may have seen while the middle part of the wound is getting filled, the periphery is being epithelialized. So there could be slight overlap, okay, in nature, okay. So again, you may have heard wound healing phases. This has nothing to do with the wound healing or wound healing types, okay, nothing to do with the wound healing phases, okay. So what you do to the wound will determine how it or how fast it heals actually. So there is primary intention, secondary intention, tertiary intention. Anyway, the all four phases would be there in all the wounds. Okay, so don't mix it up. Is that clear for you all? Just grab this point. Whether the wound heals by primary intention, whether the wound heals by secondary intention, or whether the wound heals by tertiary intention, the phases will not change. Okay. But the duration will be shorter in primary intention because primary intention wound is a clean cut wound, like a surgical incision, and it is sutured. Therefore, the amount of necrotic tissue and bacteria is less. Therefore, the amount of inflammation is less. Amount of hematoma is less, inflammation is less, granulation is less. Since the wound edges are close by, they heal, epithelialize fast. So that is primary intention, okay, in surgical wound. Secondary intention is the one I was describing all this time, okay, through four phases, and they take some time, okay. Tertiary intention is a different thing. In the word you may have seen, we do a delayed primary closure, delayed closure, okay. For example, skin grafting. So what happens in tertiary intention is these are large wounds. So they keep on granulating and all of a sudden you come and either approximate and close it, or you put a skin graft. That kind of wound is called a tertiary intention. Is that clear? Is that clear for you all?
Yes, sir.
Right. Okay. So, for example, when we do a bypass, the incisions done to take the vein, we close primarily. So those are supposed to heal by primary intention, whereas a foot wound, we just do a debrimo and keep it open. So it has to start healing by secondary intention. When we see that the wound is healthy enough, we put a skin graft. Then what happens is, or we either approximate the edges, then what happens is a tertiary intention, okay? But the wound healing phases will not change in all these things, okay? Okay? Right. Right. Now let's come to our topic, non-healing ulcers. So if everything happens as I described, then no problem. Okay, there won't be a lecture today. Okay, but I had to do this lecture because it doesn't happen that day for various reasons. Okay, the four phases does not progress. So what is chronic wound by definition is if the wound does not show signs of healing or phases of proper healing, at least by 6 weeks, you call it chronic ulcers. Okay, so beyond 6 weeks, you don't say granulation tissue will appear, the scar will appear, the epithelium will appear, okay, unless it is appearing. So beyond 6 weeks, if there's no proper phases of wound healing or signs of wound healing, you call it a chronic ulcer, okay. So in our word, you are going to see this. What are the causes? So there are 41 of you, or maybe more. And if I ask each one of you, I am sure you can give me 45 causes, okay, for non-healing ulcers or chronic ulcers. But then in an answer, you are not going to, if somebody asks you, you are not going to tell 1 to 45, which will take 45 minutes and the class is over, okay. So all these 45 causes which you are going to tell me can be classified into 3 categories, why the wounds doesn't heal, okay. So let's take for local causes. So again, think about our ward. There are enough patients with infected wounds. So local infection. Enough patients with underlying osteomyelitis. Enough patients with slough which is a degraded infected tissue in a patient with gangrenous tissues. Okay. So these wounds are, are you all thinking these are going to heal with the above mentioned factors? No. Okay. So those are the local causes for non-healing wounds. So local causes, how do you correct? I will come back to that. But in our word, why we are not attending so much to the local causes immediately is, if suppose you remove granulation, sorry, the infected tissue or the gangrenous tissue today, tomorrow they are going to have the same gangrenous tissue because their wounds are ischemic. So they have some regional causes. What are regional causes? Let's see whether it's in the. So local causes. Okay, so repeated trauma applies to these patients with neuropathic ulcers. So they don't have ischemia and they are pretty happy with the wound as well because they don't get pain sensation. So they work on it, repeatedly traumatize, and it's not going to heal. So it is going to rotate like hematoma formation, inflammation, then hematoma formation, inflammation, like that. Okay. Presence of foreign body, I said. Infection, osteomyelitis. Regional causes, that is where we come. So ischemia. So in the wards, ischemic ulcers. In the clinic, venous ulcers. Maybe in your surgical clinic or diabetic clinic, neuropathic ulcers. So those things should be corrected. So why I am listing these categories is, at the end of your short case, somebody is going to ask, what is your management? So your management should be aimed at correcting these local, regional, and systemic causes. So what are systemic causes? Again, our word. Those patients are with chronic diseases. You have enough chronic kidney disease patients. So underlying uncontrolled disease will cause systemic thing, which will result in poor wound healing. Drugs, again, you even at this moment, you have a doctor who is a post-transplant recipient on immunosuppressive drug and he is finding it difficult to heal his wound. Okay. And nutritional deficiency. So don't think it doesn't exist in Sri Lanka. If you go to again our ward, most of the patients are anemic. Okay. So having anemia, no oxygen supply, wound is not going to heal. Most of these patients have reduced albumin as well. So albumin is an indicator of low protein levels in the body. So when you have low protein, there's no granulation, no capillary formation, no epithelial formation, wound is not going to heal. So you had to address these as well. So you can't just clean the wound and do a bypass and wait. Okay. You had to address this also. Okay. Okay. So for your purpose, for your exam purpose, if you get a foot ulcer, you don't think too much. Okay. You don't think about these 45 courses. You will leave. I'm pretty certain you will be given, at least 85% of you are going to be given one of these ulcers. And if you can differentiate these things and describe these things, you are going to pass. Okay. So this one, what is a course, do you think? Anyway, before coming to the course, do you think this ulcer is going to heal? Anybody? Do you all think the ulcer which was rounded is going to heal? Anybody?
No, sir. No, sir.
What are the reasons? What is then? What is this ulcer? So the three things you had to remember: ischemic, venous, and neuropathic. So what is this?
Ischemic ulcer.
Yeah, it is ischemic. So what are the factors supporting your answer?
Gangrenous tissue.
Yes, there's gangrenous tissue. And? Yeah, gangrenous tissue. Okay. Not only the tissues on the base flow of the wound, but also the skin extending from the wound is also gangrenous, isn't it? So it is ischemic. Okay. Okay, the second one, what do you think? Is it arterial venous or neuropathy? Anybody? Second one?
Venous ulcer.
Yeah, venous. Why do you say so?
Wound is oozing and the site of the wound is in the great area.
Gate area, correct. Yes, very good. And does it contain any gangrenous tissue?
Yes.
No, it doesn't, isn't it? Where do you see the gangrene? No gangrenous tissues here. Surrounding skin, does it support your diagnosis? Surrounding area?
And the skin changes are there, the lipodermatosclerosis.
Right, okay. Do you see any varicose vein that you may not notice also? Do you see varicose veins? I can see one here, okay? Okay. If you go up, you will see. Okay, that's good. Okay, this one. So the third answer. What is this? What is that? Anybody? Third one?
It's a neuropathic ulcer, sir.
Yeah, why do you, what supports your diagnosis?
It has punched out edges and
Okay, good.
there are no gangrenous material surrounding
Okay.
it. Mm,
And so why do you think this patient has a neuropathy in the first place? Are there any, you can ask the patient of course, but since you can't answer now, why do you think this foot is neuropathy? What do you think? Oh,
pressure point, sir.
sorry.
It is on a pressure point.
Okay, good. That's a location supporting you. Yes. And do you think this foot is a neuropathy?
Sir,
Yes, sir. There is diabetic osteopathy. This is Charcot.
Okay, you want to say this is Charcot's in a sense, yeah, then you have to say look at the midfoot and the ankle area, which I haven't completely shown. She may have, but looking at up to this point, I don't think she is going to have that behind. Okay, she has. I don't think this foot has a Charcot's thing. What do you actually wanted to say rather than Charcot's? Why do you say it is Charcot?
It is deformed, sir.
Yeah, it is deformed. Okay, you are correct. This is deformed, but that deformation doesn't fit the description of a Charcot's. Okay, that
Okay.
Charcot's thing come
Okay,
here.
sir.
Okay,
Okay,
right.
sir.
What kind of deformity then do you see here?
So the foot arches are lost, sir.
Okay, okay, accepted. And compared to the position of your toes, her toe is it in a normal position or is it in an abnormal position? So, what do you think? The toes are, I mean, they don't now. So, first toe is here, second is here, third is in between, fourth is here, and fifth we can see what is it. It has a healed wound over the amputation site. So, all there is a hyperextension of the metatarsophalangeal joint. Okay. And interphalangeal joints are of course straight. So, there is a kind of foot deformity. Okay. And that is why it has appeared due to the redistribution of the pressure. There's a pressure also here. Okay. So there's a foot deformity, as you correctly said. And if you ask the patient, she will of course tell numbness. And of course, I'm sure she has pulses. Okay. Okay.
Okay, sir.
So the first one, will she have pulses with this appearance?
I don't think so.
Yeah, I also don't think so. Okay. I would be surprised if she has pulses. Okay. Okay. Second one. This one. Will she have pulses? Anybody?
Most probably, sir, because she is
Yes,
very
she would be having pulses, and you will be happy if she has pulses because you had to treat this also. Okay. If he doesn't have pulse, then no problem treating this. Okay, so treatment. Okay, so that's the next question for you all. How do you manage? Then now, of course, you can tell at least 3 words. Okay, if not 300 words. Now you can tell 3 words. You will address the local, regional, and systemic factors. Okay, that all. You all of you can tell that at the end of this, isn't it? Okay. So how do you manage? You say just you will address these things, and if you know something more, then tell. Okay, right. So local thing, we often send patients to wound toilet. I am sure if you go to the casualty theater now, there are some patients undergoing wound toilet, and if you ask what is a wound toilet, this is what is done. The registrar who is doing it either is removing a slough, dead tissue, dead bone, foreign bodies, or he is draining pus. So it is that process which is called a wound toilet. Okay. And why are we doing wound toilet? We are enhancing the process of normal wound healing. So you are doing the job of the neutrophils. You are doing the job of the neutrophils with your scalpel. Okay. So you are making the wound bed suitable for future granulation and healing. Okay. So that is what is achieved with the wound toilet. Right. Regional things, what do you do? So you come to the board and find out. So most of our patients are ischemic. So then you revascularize. So we do bypasses. You can see a graph here. Okay. Arterial, ischemic, revascularization. Venous ulcer, the mainstay of treatment. Of course, last time also I told you, you address if there are any causes like varicose vein, of course, you will address that. You will not forget that also. But counteracting the venous hypertension, you apply multi-layer compression dressing. Okay. So if you go on a Monday evening to room 19, you will see enough of patients having multi-layer dressing. And we were talking about the pulse on these patients. If the patient doesn't have a pulse, for example, then you don't compress the leg. Okay, that is where it becomes worrying. Okay. Neuropathic ulcer. Now, the answer to one of the boys who told Charcot's foot, this of course I will call it a Charcot's foot. Okay, so the deformity is in the ankle joint and the tarsal bone joints. Okay, so they have collapsed and the patient has lost the contours and it is deformed. Okay, so this is a Charcot's foot and there's a ulcer as a result of deformity due to redistribution of the weight bearing. Okay, so what do you do? So you ask her to buy a footwear, and if the ulcer, for example, is on the heel, you make sure that the heel doesn't bear weight. In this patient, of course, you make sure that the wound doesn't bear weight. So that is called an offloading. Okay. So you prescribe the patient an offloading footwear. Okay, for neuropathic ulcer. Okay, and systemic. So, for example, neuropathic patient comes. You can't just do a wound toilet and prescribe offloading footwear and send her off, okay? Because she is going to die of diabetic ketoacidosis or an sepsis, okay? So you had to address those things, okay? And all of you, or at least a patient would request an antibiotic, okay? So what are your opinions on antibiotics? Any students? Your opinion, will you give all the patients with wound antibiotics? Will you give? Yeah, that's the point. Okay. What I mean is, yeah, this you have seen this venous ulcer and neuropathic ulcers, and even bypass. After the bypass patient also, they are going to have some ulcers for some time. Will you give antibiotic just for these patients for months? Oh, how do you decide? So how do you decide is if there are surrounding evidence of infection that you will observe by the features of inflammation, then if the patient is obviously systemically ill, then you give an antibiotic. Okay. Other than that, there is hardly any evidence of antibiotics. Okay, so you give only antibiotics if there are local or systemic evidence of infection. Okay, so that's your answer. Okay. You can, of course, apply some dressings, of course, have antibiotics. Okay. And there's a thing called critical colonization of the wound. So patient will come and tell you the oozing from the wound has increased and the oozing becomes more smelly. That indicate, and when you examine, of course, there's no surrounding evidence of infection, no cellulitis. Those patients have what you call a critical colonization, then you apply topical antibiotics. Okay. There are creams and gels with topical antibiotics and antiseptics. I will show you the dressings. Okay. So that's another indication for local things. Okay. Right. That is, now we come to the dressing. So you can't go away discussing a wound without discussing about dressings. So dressing is a material applied to cover the wound. Okay. So whatever touches the wound is called a primary dressing, and whatever applied on top of the wound dressing, for example, a plaster or a crepe, is called a secondary dressing. So there are some features. So dressing becomes a big problem these days because you have thousands of dressings to choose from. The reason is there are features expected out of a dressing which is not provided by, not all the features are provided by all the dressings. That is why the drug or the medical representative comes and tell you some of these features. His dressing would absorb exudate. His dressing won't cause pain. And he will also tell his dressing is cheap and freely available. Okay. Another rep will come and tell you it is good for protection. You can leave it for a longer time. And it is easy to exchange. It has a membrane which allows gas exchange, that kind of thing. So ideal dressing should have all this in one go, but usually that is not the case. Okay. Therefore, you have to choose what is ideal for the wound. So you look at the wound characteristics and choose. Okay. So there are thousands of dressings. So you don't have to know the names of each, but you can categorize them. Okay. So you have gauze dressing. So all of you would have seen gauze, bandage, and gauze swabs, gauze towels in the hospital. Okay. Then you get towels. Okay. Nets. So Vaseline or Fusidin towel. Vaseline gauze, what you call, is a net dressing. Okay. Which is coated by paraffin, which makes a removal of the dressing easy. Okay. Then you get hydrocolloid dressing. So these are pectin materials which absorbs little amount of oozing and become gel. So in a wound which is going to become dry, a wound is oozing a little, you can use hydrocolloids. I will give you examples. Okay. Hydrogels you apply on the dry wounds. It's just like a gel. Okay. Then you get sponge-like materials like foam dressings, alginate dressings, and then transparent dressings, and so on. Okay, so categories. So gauze, commonly available, commonly used, and cheap, but the problem is it dries. And you would have seen patients shouting when the dressings are removed. And when they are removed, it damages epithelium, so you would have seen bleeding also. Okay. So to prevent that, you can use this, which you would have seen, what is called a Vaseline gauze. So it makes a removal easier because it doesn't stick. Hydrocolloid dressing will look like that, a hard gel or something. So you apply it on the wound, it becomes gel, and so it keeps the wound moist basically. Then gels, you have hydrogel, which will facilitate the wound or which will keep the wound moist. Okay. So if you see a dry wound, you can prescribe this. So the advantage of keeping the wound moist is you aid the natural process of proteolysis. So if there is a small amount of slough, you don't have to take the patient to theater. You can apply hydrogel and let the nature work. Okay. Right. Then the foam dressing, which looks like a sponge, comes in various names and which will absorb fluid. So oozing wounds, you can apply this. Okay. Silver dressing, famous these days. So you can apply silver dressing, which the silver is thought to kill the organism. So in a critically colonized wound, you can apply silver dressing, which will reduce the amount of bacteria and reduce the oozing and smell. Okay. So silver dressings. Then vac dressing or vacuum dressing. So if there is a wound which is having a large cavity and which is also oozing, so that the nurses have to change the wound dressing, for example, thrice a day, that's going to be a big trouble. So large cavitating wounds, you can apply a sponge like this and connect it to a tubing which keeps on sucking. Then what happens? The wound does, even though it is oozing, the exudates won't come out. Therefore, nurses do not have to change the dressings 3 times a day. Therefore, less trouble to nurses and the patient as well. Okay. So that is why the mechanism of vacuum dressing came. Okay. So you apply a vacuum suction. And therefore, there are some other effects as well. So I was talking about this. Rows of wound edges together when it sucks, remove the exudate. Okay. But there are microscopic effects as well. It reduces a intercellular edema as well as it promotes granulation tissue formation. So if you keep the vacuum dressing for 5 days, when you remove it, you will actually see red granulation tissue. Okay. So there are some other advantages as well. So apply to large cavity wounds with large amount of exudates. Okay. So when to change the dressing? Again, common problem. When you all become HOs, it is easy for you to prescribe daily dressing. Then it is very difficult for the patient and the ward staff. So indication for removal is when the wound dressing is soaked or when you have to look at the wound. Okay. So those are the indication for removal. Not on a routine daily basis or every other day basis. Okay. So understand that as well. And chronic wounds again, you would have seen this betadine, hydrogen peroxide, acetic acid, what else? Savlon, those things in all the wards apply to wounds. That's okay for acute wounds and wounds which are healing. But for chronic wounds, don't apply these substances because already struggling wound or already struggling granulation tissue cells will be destroyed by this. Okay. So avoid these things in chronic wounds. Okay. That's the other point. And the next point. Now see this, look at this man's foot. So of course he has a 4-foot wound. A dressing with the gauze bandage was applied, which we have cut open. And then to see, you see a line of demarcation here, isn't it? Here the skin is dark and here the skin is not so dark. What's the reason? There's a clear demarcation. What's the reason? Anybody? Anybody?
The bandage being too tight.
Yes, that's a common thing. So you can of course apply tight bandage in an accident service where they don't have ischemia. Here on an ischemic patient, if you do the same thing, next few hours, the 4-foot is going to be gangrenous. Okay. So don't apply tight gauze bandages. If you have to use bandage for some reason, use this crepe bandage, which is less, it is more friendly. And no, just apply plaster. Okay. So careful about these bandages. Right. Thank you. Any questions? So when you see ulcers, I'm sure 90% of our patients are having ulcers. Think on these terms. Okay. Any questions?
So in vacuum assisted closure,
Yes.
is negative pressure impact on wound?